Afternoon, and thank you all for joining us today for Shortchanged, the impact of chronic underfunding and underinvestment in public health. I'm Erin Morton, Executive Director of the Coalition for Health Funding. CHF is the oldest and largest nonprofit alliance working to preserve and strengthen public health investments in the best interest of all Americans. CHF is pleased to be co-hosting this event alongside Trust for America's Health. Before we begin, I want to go over a few housekeeping items. First, please note that today's webinar is being recorded. Real-time captioning is being provided today by Leah of AI Media. Thank you, Leah. For captions, you can click the More button with 3 dots on the bottom right side of your screen and choose the Closed Caption option. Because we're using Zoom's webinar format, all audience members will be muted throughout our discussion, but don't worry, we will be taking questions. To ask a question, please use the Q&A function on your screen to type your question. You can start submitting questions now and can continue to do so throughout the presentation. When submitting a question, be sure to include your name and the full name of your organization with your question. The United States spends more on healthcare compared to other high-income countries. However, our nation still yields substantially worse health outcomes, and policymakers are asking why. What can be done to achieve better results? While we won't solve this problem today, we aim to address the challenge with our experts during today's discussion. Our panelists today will share their unique perspectives on how to address the long-standing gaps in public health capacity resulting from chronic underfunding and the importance of targeting increased, sustainable, and flexible funding to public health and to prevention. You can see our agenda today on this slide. And after our presentations, we'll have time for discussion and questions from the audience. And now on to our panelists. I'm not going to read everyone's bios as you likely saw them on our registration page, but I do want to take a moment to introduce you to our speakers. Dr. Takesha Dewan Everett is the Executive Vice President of Trust for America's Health, where she collaborates with the President and CEO to shape the organization's strategic direction and implement its priorities. Krista Wazowski has 20 years of public health management experience, currently serving as the health officer for Medina County, Ohio. And Dr. Brian Castrucci is an award-winning epidemiologist with a decade of experience in various health departments and is currently the president and CEO of the de Beaumont Foundation, where he is focused on advancing policy, building partnerships, and strengthening the public health system. And now it's my honor to welcome Dr. Takesha Everett from Trust for America's Health. Thank you, Dr. Everett, and I'm going to turn things over to you.
Thank you so much, Erin. And thank you to our partners at Coalition for Health Funding for co-hosting this important event with us. My name is Takesha Dewan Everett, and as mentioned, I am the Executive Vice President of Trust for America's Health. Next slide. Trust for America's Health, or TFAH for short, is a nonprofit, nonpartisan public health policy, research, and advocacy organization dedicated to making disease prevention and health equity national priorities. Next slide. Our organization uses data and research to analyze critical public health issues and push for policy changes that will protect the public's health from issues ranging from substance misuse to chronic diseases to public health emergencies. Last week, TFAH released the report, The Impact of Chronic Underfunding on America's Public Health System. In the report, it highlights the need for consistent funding for public health and prevention efforts. Our reports are intended to inform policymakers, the public, and the media of the importance of a strong public health system every day, not just during emergencies. Next slide. One of public health's greatest challenges is that its successes are often invisible. This can make it easier for policymakers to overlook public health when it comes time to fund this critical work that is often unseen work. One striking comparison is the share of our national health expenditures that go to prevention and public health activities. In our report, we analyzed CMS national health expenditures and found that the total spending on public health and prevention represented about 4.4% of the total $4.3 trillion in expenditures in the United States. That's that tiny blue sliver on the graph you see here. As we can see, that's not equating to living healthier lives. In fact, in the US, we have a lower life expectancy than comparable nations, but with much higher cost. And despite the return on investment from public health interventions, we continue to see this mismatch in funding. Next slide. As public health threats have risen, the Centers for Disease Control and Prevention, often called CDC, top-line budget has not grown accordingly to meet the challenges. Stagnant funding has made it difficult to keep state and local health departments fully staffed with qualified professionals. A recent survey found that almost half of state and local health department employees have left between 2017 and 2021. This is on top of an estimated 80,000 full-time employee shortfall to provide basic public health services in all communities. Another challenge that we face with inadequate funding is that many evidence-based public health programs exist, but cannot be funded in all 50 states. So the states are not able to address some of the leading health crises among their residents. Here are a couple examples. The state physical activity and nutrition program, which addresses root causes of obesity, is funded in only 16 states, though we know there's a rise in obesity in the United States. The Comprehensive Suicide Prevention Program is only funded in 17 sites. And while CDC received 264 eligible applications for the Racial and Ethnic Approaches to Community Health Program, known as REACH, in 2018, CDC can only fund 40 recipients to reduce health disparities among racial and ethnic populations with the highest burden of chronic disease. Next slide. Another issue has been funding cuts to critical emergency preparedness preparedness programs. CDC's Public Health Emergency Preparedness Program, which supports core emergency readiness capacity in states, territories, and local areas, has decreased by 25% over the last 2 decades, or about 50% if you account for inflation. The Administration for Strategic Preparedness and Responses Hospital Preparedness Program, which prepares health systems for emergencies, experienced a 59% cut over the same period, or nearly 66% if you adjust for inflation. Now, while these programs saw much needed funding increases in FY23, final numbers fell short of the recommended funding amounts to build readiness. These programs are our first line of defense. Because of these cuts, public health lacks the resources to respond out of the gate when a disaster happens. Next slide. Instead of upfront funding that would work to prevent and mitigate health crises, emergency responses often depend on emergency supplemental funding. In most cases, this funding is temporary and does not create or sustain vital improvements to public health infrastructure. Supplemental funding cannot build needed solutions overnight. It takes time for funding to not only be approved, but also to best get resources out the door. In a public health emergency, every second counts, and these delays give threats even greater chance of taking hold. It also means that the workforce is depleted and people cannot be rapidly hired and retained with short-term funding. Now, once that supplemental funding expires, the nation's public health system is again left vulnerable to the next crisis, and this boom and bust cycle repeats itself over and over again. Only consistent funding over time can prepare the public health system to prevent and respond to crises in a timely and adequate manner. We are seeing this yet again as the debt ceiling agreement rescinded money that had been intended to shore up public health and vaccination systems over time. And we're hearing Congress discuss cuts for health spending. Next slide. This consistent underfunding of the health system and challenges, and the consistent underfunding of the health system and challenges that we see already are harming our already depleted public health workforce. Public health leaders must rely on outdated data and lab systems to accomplish their mission on top of dealing with limited resources. Our public health system is not able to react and respond to pressing health matters as quickly as it would like, such as addressing health inequities and root causes of health issues, in addition to emerging threats. As a result, healthcare costs rise as the public health system lacks the resources necessary to implement innovative strategies and other forms of early intervention to prevent illness in the first place. Next slide. So our report includes recommendations across a number of areas to make sure we are allocating appropriate funds for the nation's health. We seek increases to CDC's top line that would enable the agency to invest in cross-cutting initiatives that strengthen our public health system and ensure effective programs can reach all states. It's important to bring public health into the 21st century by creating sustained funding to build modern public health systems, support state and local laboratories, and recruit and retain qualified public health workforce. Investments in health security will protect the nation from the next public health emergency and are a much better alternative to the boom and bust cycle of supplemental funding. Investments in vaccine infrastructure, countering antimicrobial resistance, and climate adaptation are greatly needed. Some populations are at increased risks of experiencing poor health outcomes due to societal conditions. It is important to develop strategies that specifically promote health equity and that target the root causes of disease and illness by addressing the social determinants of health. Increasing investment in chronic disease interventions related to physical activity and nutrition are needed to lower rates of obesity across all age groups. In addition, public health should have a more active role when it comes to addressing the needs of our nation's seniors. Finally, primary prevention efforts are critical to reducing the rate of death from suicide, drugs, and alcohol. Strategies to address these deaths of despair include comprehensive suicide prevention programs, preventing and mitigating adverse childhood experiences called ACEs, and school-based services to reduce risk among youth. I want to take an opportunity to thank staff at Trust for America's Health, who've done a tremendous job of analyzing the data and bringing forth these wonderful recommendations that are very critical and important for us to advance the public's health. And with that, I'll turn it back to you, Erin. Thank you for listening.
Thanks, Takesha. And next, we're going to hear from Krista Wazowski with the Medina County Health Department in Ohio. Just a reminder to be thinking about your questions. If you have some for Takesha after her overview of the report, you can start to type them into the question and answer function. And I will just take 1 second as an aside and note the question that came into the chat that the event is being recorded and the recording will be made available on the TFAH website after the event. Krista, over to you.
Thank you, Erin. And good afternoon to those joining us for this discussion today. I'm Health Officer Krista Wazowski, and I'm pleased to offer some grassroots context to how the funding situation described by Dr. Everett impacts your local communities. I think all of you watching may be more familiar with the functioning of HHS or CDC or perhaps a state health department, but local work is very different. Local public health makes a direct impact on the health of our communities, and we're the ones who are ensuring that the work is getting done to achieve the federal public health priorities that are laid out for our nation. Local public health departments are both responsible for service provision and for strategy. We're the ones out there collecting the data that rolls up into the systems that are used by others and by us to target programs and services. In local public health, we're the ones who are the ones discovering the first signs of emerging health issues in our communities. We are front lines for the opiate crisis, for the rapid rise of vaping among our teens, and certainly for COVID. In a moment, I'll talk a little bit about those three particular situations, but first, next slide, I'd like to give you a little bit of background for you. Ohio is the 7th largest state by population in the nation. It's divided into 88 counties, with each county and some cities maintaining a local health department. The result is a system of 113 departments working together across the state to serve our 11.75 million residents. Next slide. My district, Medina County, is a singular agency that covers one county. It's a bedroom community to both Cleveland to the north and Akron to the east. And I have just over 185,000 residents. Next slide. This slide from the World Population Review shows you the growth that I've experienced in my county. It began before I came in the 1960s, and it's continued until today. But the pressure today is on me as their health officer to serve more and more residents with largely stagnant and often siloed funding. And I'm doing this in increasingly complex public health challenges. Next slide. This shows for you the funding mix for the Medina County Health Department last year. I have 42% comes in fees and contracts, 33% in tax levies approved by my local voters, and 24% grants. And I do have less than 1% as a state subsidy provided by the Ohio legislature. So fees and contracts, those are straightforward. Those are unrestricted funds. Those are restricted funds that I have, but my unrestricted funds are with my local tax levy. I'm fortunate, not all health departments have those unrestricted funds because you can't use current resources to bring those in. You have to raise outside donations. You have to have a community group of volunteers to pass a levy every 5 to 10 years. And in Ohio, less than half of all health departments have that kind of local flexible funding. I'm fortunate, I have two. One has collected the same base amount since 1992 and one since 2009. Yeah, the same base amount. So living on that base amount over time with the changes in what you need to pay for in that time is challenging. The amount itself, though, isn't the only barrier. The timing and the restriction on that money also matters. For example, I have to set aside a third of that unrestricted levy money to front money for the grants that I do receive. For me, that price tag in my agency is over $1 million that I have to tie up in order to bring grants into my agency. I have one federal direct, I have one from a state public safety organization, and then I have 7 that come to me from our state health department as a pass-through, and those include WIC, Emergency Preparedness, and the new Workforce Grant, which are larger grants. So I need to have money to receive money, but it's even more than that, because both federal and state decisions can directly impact my ability to serve my community. Because every time a federal agency or my state makes a new funding priority, they take a grant that we've had and they change the focus of it. I may or may not be eligible for that funding. So then I need to assess if a program that I've already had is still needed in my community or wanted by my community. And then I have to find ways to either fund it or retrain staff who had been working on that grant if that funding goes away. So for example, for 22 years, I've had maternal and child health block grant money, but state priorities no longer match what my community needs are in that area. So I won't be funded the next grant year. So I have to decide how to maintain that programming that I have, the needs that I have. I have right now a patchwork of integrated naloxone access, integrated harm reduction, and drug overdose prevention grants. But I've been told that at the end of this year, those are collapsing down into one smaller grant and one contract. So running a local health department is hard. You see the needs, you have the public demanding action to either start something or continue something that you've already been doing. And then you have limited resources to take action with. And often those demands come in the form of new health issues. I mentioned 3 at the beginning of my comments today. Let's talk first about opiates. In 2012, opiate-related deaths were beginning to rise. In 2015, my state made naloxone, the medication to reverse opiate overdoses. They made that available to Ohio counties. The catch was that you had to have the staff time to provide local training, naloxone management, distribution, and reporting. I was able to use my levy money, and I had a local grant from my Alcohol, Drug Abuse, and Mental Health Board to help with that. Larger counties were being funded to start opiate task forces. And in 2017, Cuyahoga County, which is where Cleveland is located, shared $15,000 with my county to allow me to start up a formal opiate task force. Then in 2020, federal funds came to my agency by way of our state health department to fund this work. So 8 years from recognizing a growing health issue in my community to getting funds down directly to me at the local level in a meaningful way to do work to prevent that health issue. Just another example, let's talk about vaping. The National Youth Tobacco Survey showed the percentage of high school students. In 2011, we were at 4.5% of the students had ever tried an e-cigarette before. In 1 year, that went up to 10%. And I was seeing that same trend in my community. And at the time, I don't believe we knew that vaping cartridges had the equivalent of the nicotine that's in a pack of cigarettes. And we didn't know the health effects, but we knew that heating up something, a liquid, and putting it into the sensitive lungs of our teens was a really bad idea. So my staff, using my local levy money, worked quickly with our juvenile courts and with our public schools to offer an education program that was in lieu of court sanctions. So we brought in parents and students together and educated them about e-cigarettes, about tobacco addiction, nicotine addiction. And it was enlightening, and it changed the conversation that I was having in my community around vaping. 7 years later, mid-2019, that's when federal funds came to my county to address youth vaping. So I receive now $12,000 a year, and it's part of a larger award that I get for a general tobacco control. And I'm grateful for the funding. I don't want to say that I'm not, because I most definitely am. But had I not been fortunate enough to be in a county whose citizens put forward a levy for me to have unrestricted funds, I couldn't have addressed that issue as quickly as when I first recognized it. The third thing I mentioned was COVID, and this discussion certainly today is not about COVID. But I'd be remiss if I didn't mention how that long-term lack of investment in public health left us challenged to be able to provide what was needed in that crisis. The one example I'll give, and there are many, but this one really stands out to me. It was in the beginning of 2021 when cases were rising and vaccine was available, and it had just started going out into the public. And my citizens, the media, my legislators, they were all asking me to tell them the data on vaccination status of people hospitalized with COVID, not for COVID, not with COVID, for COVID. They were really specific about that. But the problem for me was that our state supply disease reporting software system, which was created before the iPhone was developed, didn't connect with our state vaccination system. So my team had to sift by hand through reported county cases each day to find those that were hospitalized, and then look up their vaccine status in a different system, enter it back into the first system in order to have a report. But there was another limitation. It's actually a policy limitation to some extent, but in my state, everyone isn't required to report vaccinations administered into the state vaccine system. So at times, we had to wait for the hospital infection control team to find out from a family member or the person, if they were able to tell them, given their health status, if they've been vaccinated or not. So here I was, I'm a county health commissioner. I had to tell the public and the legislature that I couldn't give them what they were asking for. And I wanted to give it to them more than anything. Heck, I wanted the information because we were trying to figure out and make policy as things were happening. But the truth was, I had the limitation of the system I was working with. And that was embarrassing. It was embarrassing to admit, but I needed people to understand that it wasn't because I didn't want to give them an answer. It wasn't that I was pushing a particular narrative about vaccine and COVID. It's that I was working with an antiquated and limited system. And that's the case throughout our public health system. We don't have that consistency across our nation. We don't have it even within our own states. And that lack of funding, that critical infrastructure, that investment into the people who are doing prevention every day on the front lines it's affecting the health of our nation. So we as local public health, we're out here working 24/7. We're at the front lines, and we need the adequate resources to serve our communities. I thank you for your time today, and I look forward to your questions. Erin?
Thanks, Krista. That was really helpful to look at how the funding is being used at the local level, how important federal funding is, and kind of the impact that it has on the ground. So appreciate that context for all of us. So finally, we're going to hear from Dr. Brian Castrucci from the de Beaumont Foundation. As a reminder, continue to submit your questions. We have lots of good ones coming in about funding and its impact on public health. So I'll turn it over to you, Dr. Castrucci.
I take myself off mute. You would have thought 2 years of this, we'd all have this down by now. Good afternoon, everybody. This is a pleasure to come speak here and share the stage with some wonderful speakers. The US is the 8th richest country in the world by GDP. And what I have learned throughout my career is the way that you understand the values of any organization is by looking at its budget. And I think that's what we've seen today. The budgeting that we've done around public health is simply inadequate, and we have the results to show for it. We are 41st in life expectancy. We are 55th in infant mortality. We are 32nd in maternal mortality. Yet we are still first in military spending 3 times more than the country spending the next most amount, that's China. We spend more on healthcare, but get less out of it than similar countries. And we continue to medicalize and criminalize our health problems, taking the responsibility and placing it solely with the individual rather than looking at the tapestry of community and how we should be solving problems together. Now, most of the people, we have 316 people on this call, and most of us are very fortunate, and our health is probably good. You know, I'm very fortunate. 2 years ago, I had a heart attack. I had an ejection fraction of 34%. For those of you who are medical, you know, that's not so good. Look, I can see Krista, and Krista's like, whoa, right? So this is not a good ejection fraction, but I was able to get really healthy really fast. And I wondered why. Was it my diet? Did I change my diet? Was it my exercise? I started to exercise. No, man, there was one reason I got healthy, and that's privilege. Because in this country, health is a luxury item. That's what we are trying to undo with better public health funding. And if we don't really think and invest in public health, the bill will come due. We've already lost 1 million American lives to COVID. We've lost people to opioids. We've lost people to diabetes. We've lost people. We continue to lose people, and the funding doesn't come. This is a decision. This is not something we don't understand. It's not something we don't know. This is an absolute decision that our political leaders are making. We come out of one of the worst public health crises in the history of our nation, with public health being more politicized than it was before, with public health being under a greater attack than it was before. We are prioritizing medical freedom over the public's health. And in doing so, we are risking our continued safety, security, and economic prosperity. That is what we are gambling with. So everything you've heard today, we can continue to say these numbers. TFAH has done an amazing job of putting this report out annually. And those of us who believe it, applaud it. And those of us who don't care, ignore it. We need to find a way to engage those who are gambling with the future of our nation by not investing in public health, and help them understand that this is a critical time. We already have the next pandemic on the way. We all know that. We warned for decades that this was coming. Imagine for just 1 second leaving a military conflict where we lost 1 million American lives on American soil, and the response was to cut military budgets. Or if I told you that half of the military had left their job and our response being crickets, there would be national outrage. But here we are, public health practitioners, fewer of us than before. And the money, even if all the money came, the money's not enough. We need to understand how we rebuild a public health system that is responsive at the local, state, and federal level. CDC has done an amazing job putting $3.2 billion into our public health infrastructure. Now, of course, that's over 5 years and to more than 100 different grantees, but it's something. But in 5 years, that money runs out. And the most important person for our health going forward are our governors. They will make the decisions as to how that money is spent. They will make the decisions about how we rebuild public health. We need to find national unity around public health and find it fast. Make sure that public health isn't a decision whether we have it or not. If we continue to think that way, and we have political candidates who would advance their own ideologies by attacking public health, we must realize that this places all of us in jeopardy. None of us are an island. And yet we continue to believe that we can make individual choices, and that's the whole kind of summation of our health. This has to stop. This cannot be seen today as a set of data that are intriguing or interesting. It must be seen as the call to action that it is. You are determined, your values are most clearly communicated by your budget. And Congress is telling us, both Republican and Democrat, everyone are telling us about their values. And their values are not in the public's best interest. They are not in public health. If we do not rectify this, COVID will look like a good day at the park for the next time around, because we already have fewer public health practitioners than we did at the start of COVID. We are already in worse shape now to prevent the next pandemic than we were at the start of COVID. So if I'm around for the next pandemic, I guess we'll sit there again and say, we told you so. We warned you. We must be full-throated in our advocacy to ensure that that doesn't happen, and that's not our role next time. We must put these stakes clearly as to what they are, and that this crisis of public health funding is as critical as any in our country, and one that should not be politicized or trivialized, because we are taking a jackhammer to the foundation of our own house. And when the house breaks, we won't have enough people to fix it. I appreciate your time and attention. I hope you take this call to action seriously. I know you will, because I know I will, my fellow panelists will, but we have to get to work, and we have to ensure that the future of this country is both equitable and it continues. And the only way we're going to do that is by investing in public health.
Thanks, Dr. Castrucci. That was a great final presentation. And that concludes our panel presentation. And we're going to now open things up to questions and answers. And as I mentioned, we've already gotten some really good ones in the chat, some key themes that are popping up here. And I think, Brian, I'm going to go back to you for this first one. We've heard a little bit from a couple of you about workforce, and we heard that a large portion of the public health workforce has retired since COVID. And so one of the most pressing public health issues is workforce recruitment and retention of our current workforce. Can you comment a little bit on how the public health student loan forgiveness and salaries, as well as ongoing public health workforce training, are part of the plea to Congress and legislative agencies in terms of addressing the underfunding of public health? And happy for others to comment on this as well. Krista, you may have some thoughts.
So let's be thoughtful about what levers we can pull to improve our workforce. Right? When you think about the workforce, the public health workforce, you're talking about 3,500 different systems when you think about the states and the locals. So there's no magic wand to say we need to increase public health salaries. You would have to do that 3,500 times in 3,500 different systems with 3,500 different ways to get that accomplished. So that's not an easy solution. There are no easy solutions, but there is a lever that we can pull with loan repayment. I love our schools of public health, but come on, we all know they're not cheap. And so if you're going to go to a school of public health and you're going to incur $70,000, $80,000 worth of debt on top of your undergraduate loans, then going to work for that health department becomes really challenging. Loan repayment is a singular level that Congress can pull, and making it easily accessible and something that everyone is eligible for, we could make governmental public health more attractive as a destination workplace. That's why it's important, because it is a singular thing that we can do, and by one action impact everyone. Most any other action in workforce, it will take doing it 3,500 separate times. But this we can do once, we can impact the workforce and have a measurable effect on the future of our country.
And Brian, really to piggyback onto that, the skills that we need even within public health have changed vastly in the last 20 years. So we're recruiting people not just from our public health schools, but really people with social workers and statisticians, math, a lot of different students from all across the educational field. And that's what we need if we want to keep an edge on ongoing prevention and having a workforce that can truly do the work that we need to do in public health today at the local level, the state level, and the federal level.
Takesha, anything to add on that before we move on?
I think it's well said. I'll go ahead and go to the next question.
Perfect. So Krista, we got a question specifically about the local level, and I'm wondering if you can comment a little bit about what strategies employees of local public health departments can employ to advocate for increased state and federal funding, realizing that both of those are important for it to get to the local level.
Yeah. Sure, Aaron. I think at the local level, I know there's a struggle in understanding the difference between advocacy and going beyond what you're allowed to do as a governmental employee. So we always say education is the key, and working through our local leaders, our local legislators, our state legislators, just to help them understand. I would really encourage people to have folks come in and visit a local health department. I think when they walk in and they see the vast work that we do in so many different areas, they're always amazed that one little department touches so many facets of life in a community. So I would start there, really about educating what it is we do. And I think we go from there.
Takesha, I want to go back to the TFAH report that you talked about, and wondering if there's anything that you can highlight in the report for us this year that's maybe an improvement from last year, or specific things that you want to highlight that really stood out as kind of different from where we were this time last year.
Thanks, Aaron. I want to pause for a second and want to answer the previous question, and then I'm going to answer that question if you don't mind. I just want to echo what Krista said and add to it that telling your story and telling stories are really critical. As I mentioned in the beginning of my remarks, often when public health is done right and done well, it goes unseen and unnoticed. And I think it's really, really critical that those who are on the front line, workforce individuals, are sharing the stories of what is happening in their local communities and doing so in a way that is accessible and can be acknowledged by the folks who are making policy and funding decisions. I think that's really, 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 really critical. To your question about what have we seen in terms of the last report to this one, I would say that since our previous funding report, we have seen some increases in key areas, and most notably in emergency preparedness. But that being said, funding is still below recommended levels to be adequately prepared for the next emergency. And if we continue to see flat funding of key programs, it's going to be an issue, especially when it comes to chronic disease in the United States. So this again is that boom and bust cycle that we're talking about. When we're looking at inflation and accounting for inflation, we're actually cutting public health funding. So it's the most pressing issue since the previous report. And I think it's really important that we focus on ending the kind of recession and the boom and bust that's happening around pandemic response for our emergency funding. And that's really, really critical and something that I think we should just reinforce and talk about.
Okay, thanks. So we're getting a number of questions about advocacy and what organizations can do. We talked a little bit about what individuals can do at the local level. Brian, we had a question come in specifically about what the De Beaumont Foundation is doing to advocate to policymakers. And Takesha, you may be able to comment on what TFAH is doing. And then I'm also happy to weigh in on the Coalition for Health Funding's perspective, since advocacy is, of course, near and dear to our heart. So maybe we can just spend a little bit of time here and tackle some of these questions together that we're getting.
Well, for De Beaumont, we take advocacy in a couple different ways. So we're not directly at Congress advocating for policy change. Where we do work is at the local level, trying to pass policies that really advance health for all. So I would encourage you to look at cityhealth.org. We give the 75 largest cities an assessment and medal rankings. So we'll give you a gold, a silver, a bronze as to whether you have the policies that you need in place to really have a healthy population. And it's not always what we would think about as like health forward policies. It's policies that include things like clean indoor air, but also things like paid sick leave and green space that impact people's health, but though we wouldn't necessarily think of them as a public health policy. Cityhealth.org, something worth checking out. We also do a fair bit of research in workforce. So the Public Health Workforce Interest and Needs Survey is something that we've done since 2014 to help understand where the public health workforce is in time and space. It was those data that allowed us to quantify the departures in the workforce between 2017 and 2021. Again, half the workforce left between 2017 and 2021, 75% of the workforce under 35 left. We've also conducted a fair bit of research in the number of FTEs that we need in public health. And we came out that we need 80,000 more FTEs in the governmental public health workforce just to do, not to do surge, not to do, response, but just to do the basics of public health. And that was before these departures. So now there are places in this country where there are more vacancies than there are public health workers. And we are actively trying to think through how we help convince legislators and elected officials, not only at the federal level, but at the state level and the local level, about the value of public health, right? We've watched concepts like medical freedom come to the forefront. We need, and someone said in the chat, what's a way that we can quickly communicate to politicians.
Yeah.
There are some tools out there. There's phrases.org, phrases.org. And I encourage everyone to check out the Public Health Communications Collaborative. Is something we work on with the CDC Foundation and TFAH and Kresge. There's going to be a lot coming in the future to help us do this better, communicate better, build better partnerships with businesses who city council is going to listen to a business a lot sooner than they're going to listen to a public health practitioner. We need to start to mobilize our friends and identify our friends. And so I think that's some of what we're doing to try to support the public health workforce. But we're also open to ideas that, the practitioner community thinks that we need to advance this effort.
Yeah, thanks. That's great. Takesha, do you want to talk a little bit about TFAH's advocacy?
Sure. So our advocacy focuses on mostly the federal level, but we also use and disseminate the information that the data that we synthesize in our reports to ensure that it's reaching state and local levels. So in general, we're looking at all of our things kind of work together. We produce the data and we synthesize and disseminate the data. We use that evidence to create recommendations and to support those recommendations to our Congress people as well as individuals in the White House and the administration. And because we have such robust state level data, those reports can also elevate and tell the story using rigorous evidence to tell the story on the state and local level. We also look at social determinants of health, chronic disease, other aspects of that in order to ensure that we are looking at all aspects of the public's health and the public health infrastructure that's necessary to respond to those critical public health needs through our government relations team. Now, I want to pause for a second and say not just our government relations team, it's an all front effort at Trust for America's Health, because we're all focused on ensuring that we have the best evidence to produce the best story that we can tell to convince the folks who are making decisions, as well as the public, how they can use that information to make those changes. and we work with our partners. So I can't, Brian mentioned it already in terms of how we work with the public health communications collaborative, but I also want to uplift that we have other partners at ASTO and NACHO that we work with as well in terms of getting information out. And of course, our partner today, the Coalition for Health Funding.
Yeah, thanks, Takesha. And just to pick up on that thread, so, TFAH and ASTO and NACHO and many other partners are members of the Coalition for Health Funding. We have over 85 members across the public health and healthcare spectrum, and we collectively work together from an advocacy perspective, looking at that top line funding level for every program under the U.S. Department of Health and Human Services, and really advocating for increased funding across the board. So we have we like to use the phrase "a rising tide lifts all boats," and with all of our members talking about that top line number, not necessarily focused on one specific line or another, or how that one line is going to impact a program that's important to you or to your members. But we really need those voices within the coalition lifting up that overall funding line. And so as you guys talk today about the importance of sustained funding, right? Annual funding, federal funding that's reliable, that we're not relying on emergency funding constantly like we did during COVID. That's really what the coalition prioritizes, is that need for that sustained funding. And we, we do congressional visits with our members. We send information and letters to the Hill. We rely on materials that are created by our partners like the de Beaumont Foundation and TFAH to make advocacy points to policymakers, both on the Hill and within agencies. So partnerships, I think we've heard a lot today, are super important in all of this advocacy work. Krista, anything else on advocacy before we talk a little bit more about sustained funding?
I think you guys covered it well. Thanks.
So I want to highlight this issue of sort of the cycle of funding for public health by emergencies, right? This is something that is highlighted in the TFAH report. This is something that we know now from COVID is a real challenge. It creates a challenge for health departments at the local, at the state level. I'm wondering if maybe we'll start with you, Krista, but others too, if we can sort of comment on this need for sustained funding. Where did emergency funding work during COVID? Where was it successful, but where did it fall short? And where are we now as we're looking at this potential cliff of emergency funding moving away from COVID? We've heard about potential rescissions of COVID dollars. We've heard about money that's going to be removed from that's potentially not going to exist going forward. What is the impact of all of that as we think about how to talk to policymakers about the need for sustained funding?
So emergency funding surged into us, not the very beginning, but a little bit ways into COVID. At our state, it came in all these individual, it felt like a death by 1,000 cuts. We had 8 different grants at one time. One was focused on one aspect and another aspect. And that was because of our state system limitations for how they could push out money to us. Everybody wanted it a different way, them most of all. But that funding in the emergency helped cover some of the pulling of staff from all the other projects they had worked on that normally would have funded them. So, that emergency funding in the moment certainly is not a replacement for our day-to-day public health needs. And it was never meant to be. That's why I said this conversation isn't about COVID. The status of our system, as Brian talked about, as Takesha talked about, that was long before COVID. So when we're talking about funding, I'm not talking about replacing emergency money. I'm talking about making that investment long-term in public health so that we can be ready for emergencies. And I'll tell you what's changed. The levy that I talked about that collects at 1992 base value took me 3 tries after COVID to get that replaced by my local voters. And that was the politicalization of public health that Brian spoke about. And those are the reality. That's the reality of what we're dealing with now when we're talking about what we need within our system. It's kind of overlaid with some of that. That's why it's so important for all the partners. And as you said, people coming in from outside of the traditional public health to really talk about and to advocate for a system that can truly do what it needs to in this nation.
Brian, Takesha, anything on?
I absolutely believe that we need consistent funding in public health, but asking for it is not going to get it done. We're going to need to understand, we're going to need to make public health something that people value. And listen, legislators aren't always going to listen to the do-gooder public health person. Okay, but they are going to listen to the business community. Right. Remember during the pandemic, one of the times Trump relented was when there was a New York Times article, a New York Times op-ed signed by, it's like 100 business leaders, and he relented. Now that's powerful. And so we need to start building coalitions that advance public health and doing it for a reason that businesses can understand how we help them. And this is something that I think we've talked about for a long time in public health. We've talked about how the business community will benefit from better public health, but we've never been able to realize it. All right. And I think we have an opportunity coming out of COVID to make some of these relationships that weren't there before. I would direct people to the Health Action Alliance, which really did an amazing job of translating some of our public health science and jargon into actionable steps for businesses. Right. We need, folks like Krista need to be at their Chamber of Commerce, routinely. They need to be making relationships. The worst thing I saw in the aftermath of COVID, and I saw people say, oh, thank God, I don't have to do these COVID lives. I have to do these Facebook lives. I don't do these Instagram lives anymore. You need to do them more. You need to do them every day. You need to be not running a health department. You need to be out at the Rotary Club, out at the Kiwanis Club, out at every opening of a TCBY yogurt store. I don't care what it is, be out there. Okay, we're not just going to ask for funding and get it. We're going to have to create a value proposition where there is demand for better public health such that people are willing to fund it. And so how we do that, and we do it together, and I've watched the chat with folks asking, what about this funding? What about that funding? What about this funding? We need to really break through our silos. I spent a lot of my time as a practitioner, as an MCH person. And honestly, I'll admit this to you, as long as the block grant was held harmless, the rest of it could all burn. Right? Because that's what I cared about. I cared about MCH. I've matured beyond that belief and understand now that it's the whole system, right? It's not HIV, it's not immunization, it's all of it. And we need to start talking to people every day about the importance of public health so that Takesha can never say again, hey, sometimes when public health does its job, no one really knows it happened. We need to stop that. Okay. And I'll tell you, when I do something in the house, I tell my wife. I don't wait for her to find out. I go tell her, I did this today, I did that today, so that I have value to her. We need to do the same thing in public health.
I couldn't say it in any better, Brian. I think we have to focus not only on value of public health in an emergency, but remembering emergencies are going to happen. That's a given. But public health is every day. And we need to fund it that way. We need to respect it that way. We need to see the workforce that way. And we need to build the infrastructure consistently. That's the story we have to consistently tell over and over and over again, as we are, as Brian said, garnering support across sectors to really focus on what is it we need to do to advance the public's health. And I want to just say, someone had mentioned in the chat earlier about taking away from the left hand to the right hand. They said it a little bit differently, but that's how I'm going to say it. What we're talking about in this funding report and the underfunding of public health is not about saying one thing is better than the other or something else needs to happen. It's the collective understanding that what we're doing is not working. And if we continue to do it, we're going to continue to have failures in our public health system daily and in emergencies. So that's the point. We need to come together, value public health, build a strong, respected public health infrastructure that can address the challenges today and in the future, unseen ones that we don't even know, to advance our public's health.
And we're talking about funding today because funding is critically important, but there's a beautiful chat going on, right? About what about this? What about that? It's all of it, everybody, right? It's about the business community. Yes, there are people in the business community who are annoyed at us. And you know what? They're right. We did harm. I think we did the right thing. I support the fact that we did lockdowns, but man, we did harm. Some of those businesses, people worked their whole lives for those businesses and they never opened again. We got to own that. What we didn't have was the trust with those businesses. You can't have the health commissioner meet the president of the Chamber of Commerce the first time, introduce themselves, and then the health commissioner say, oh, by the way, I'm shutting you down. That's a bad first date. No one's swiping right on public health then, and nor should they. So we have to look at all of this. How do we work with the community? We need in every health department an assistant commissioner for community engagement. And that person should be of the community at the table, every decision that's made. But that's something we can do now, but we need to all work together to build a national workforce plan, to build what an ideal health department is and then work towards it. And we'll need the funding to make it so. But we need to find a group identity like we've never had before. Because right now, I mean, remember Horton Hears a Who? I don't know that we'd escape the oil because we're all not saying the same thing. We got to get on the same page, start talking together, and have a national plan to move public health forward. And that will really rebuild our public health infrastructure. And ultimately, we can sit back someday and say, save the nation.
This was great. And I was going to turn it to each of you to give some closing remarks, but Takesha and Brian, those were great closing remarks. Krista, I want to make sure you have a minute to say anything else in follow up to what the two of them outlined here. But it looks like you're shaking your head.
I just love that I love that we have organizations and people who get it, who care. And I couldn't agree more with the comments that were made to close. So.
I mean, I'll just say I've been sitting here, you know, my job as moderator is to ask questions and to try to figure out what's coming in both from the chat and from the Q&A. And the chat is just impressive. People have ideas, they have feelings. I hear people are kind of getting excited and energized again. So I feel like, you know, the point of these kinds of conversations is to find like-minded individuals that we can hear from, that we can partner with, in addition to sharing our thoughts and ideas with policymakers and with Congress. And so I think it's been hugely successful. I've enjoyed the conversation with all of you today. I think, you know, this issue is important for us to continue to discuss and to work and to try to solve as we modernize our public health system. As I promised, we were going to discuss it today, but probably not solve it today. But I think ongoing conversations like this are important. And so I really want to thank our panelists. I want to thank AI Media Captioning Services and all the behind the scenes staff at TFAH, and all of you for joining and for a really vibrant chat conversation in the chat. Of course, we could not even get to all of the questions because there were so many good ones that came in. We did record today's event, and so a recording along with the slides and some additional resources will be made available on the TFAH website, tfa.org, in the coming days. And on behalf of TFAH and the Coalition for Health Funding, I just want to thank you all once again for joining us today, and thank you to our panelists, and enjoy the rest of your afternoon.